These conferences, we always have an aim that we include the whole health professional team, and we're always delighted when we get a high turnout of nurses and other allied health professionals to these meetings. And it particularly gives me great pleasure today to introduce you to our next speaker, Tootie Bueser, who, actually she'll say that properly again when she stands up, because I haven't done her justice in her name there, who's a clinical doctoral research fellow at King's College in London, and also works as a cardiac genetics nurse within both King's College Hospital and Guy's and St Thomas's Hospital. She's the president-elect of the British Association of Nursing in Cardiac Care, so comes to us with a great set of credentials to share with us some of the projects and strategies that her teams are putting together in terms of helping patients longer term. Tootie.
Thanks, Alison, and thank you to Cardiomyopathy UK for inviting me to speak on the long-term needs of patients with cardiomyopathies. When I was preparing this talk, I came across this picture in the news. This is during the floods in Texas, and you can see here that it's like an ordinary day there. This lady's got her legs crossed. This one's, I think, maybe doing some knitting. Maybe she's going to get a cup of tea. And of course, the resident cat is there somewhere, sort of looking smug as always. So, like an ordinary day for them, except they're all waist deep in water. And I think sometimes, and I thought about our patients, you know, they get on with lots and lots of things, looking after their children, going back to work. But then, you know, and their resilience keeps them going. But then there's that sort of flood waters that I think that also engulfs them. And I think in terms of either there's cardiac problems or any psychosocial impact of this condition. And I think, you know, we can really, as clinicians, help get rid of those flood waters or keep them at a minimum for our patients. Okay, so when I thought about the top 10 long-term needs for cardiomyopathy patients, I came up with this list. And number 10 is going to be is going to be a surprise at the end, but I hope that by the end of my talk you figured out what that is, because that element will help you get through 1 to 9, I think. And just to say that those ladies are all safe, none of them were hurt. So number 1, initial assessment and long-term medical follow-up. I think it's really important to get that initial diagnosis and management right for your patients. And when you're sending them home after the consultation, give good feedback and have a plan of care for them. And through my PhD, I'm doing lots of reading. And part of that reading, I'm kind of discovering the evolution of the Inherited Cardiac Condition Service. And patients who were seen in the 1980s or 1990s, they came up with these comments on their care. Incompetent, confusing, inconsistent, having incorrect treatment, their relatives keep dying, and they're not being listened to. And this, usually, the provider of care would be a single clinician. And of course, science, it wasn't our knowledge of cardiomyopathies wasn't that great then. And then fast forward to the current time, late 2000s to the present, a lot in the literature, you can see patients commenting on the care that they receive as clinics are a source of support. They get reassurance. The staff are warm and supportive, particularly genetic counselors, and they have a positive experience, no matter what the sort of diagnosis they have is. And this is more a team approach, multidisciplinary team. And so for those of you who know who I work with, I'll let you figure out if you think they're more of a George Clooney or more Groove. Okay. So this is our service at KHP, and we try to provide a one-stop shop for our patients where they can get accurate diagnosis, risk stratification, appropriate management, and then we also bring in the genetics component of that so that we can do the family screening, any genetic testing that's required, and any sort of predictive testing that can be cascaded on is done, and also all in all a package of patient education. And of course this has been recommended by the HCMEC guidelines that patients with cardiomyopathies or inherited cardiac conditions should be referred to a multidisciplinary team with expertise in this field. But in our experience, lots of patients still drop out of follow-up, and it's been documented that 25% of known carriers also drop out of follow-up. So we went back to our patients and kind of asked, why is this happening? And one of the factors is that, you guys are just too far. I can't you keep coming back, going to the tertiary center. And so we thought, okay, we'll bring it to you. And so with the help of the British Heart Foundation and the Miles Frost Fund, we're trying to set up a hub and spoke model at KHP. And so here the hub will be St. Thomas's Hospital. The patient will have their initial visit and management plan with us, and then they will be discharged back to their local hospital. But then you'll have the cardiac genetics nurse coming from the tertiary center supporting that local follow-up clinic that they'll be seen. And all is not lost. Obviously, if things go wrong and patients have more symptoms or need more complex treatments, then there will be a virtual clinic, an MDT coordinator who will then, we can look at the case again, and then the patients can then be plugged into the tertiary clinic straight away. So hopefully, next time maybe we can give you some of the outcomes of this project, but we're very optimistic about it. And then number 2 and number 3, symptom support and medicine and device management. And I think a lot of that was discussed this morning, so I'm not going to go into that into much detail, but just to stress about AF, early detection of AF and treatment. Again, although some patients will have a genetic condition, they will can also be at risk for coronary disease, which is much more bread and butter. And then in terms of devices, the ICDs, in all of the research that I've been doing, it becomes really problematic for patients, and they go into profound sort of psychological distress when the ICDs start malfunctioning or they have inappropriate shocks. So I think it is really worth a lot of time counseling your patients when you're considering an ICD for them, and also have that adequate support when with the device. And then just the last bit for monitoring is embracing technology. At the ESC, Eric Topol gave the keynote speech, and he presented his medical selfie. So I think this is going to come into play a bit more for our patients, and it gets them engaged as well. So hopefully more to come with this type of monitoring. Now, before I go on to the psychological needs of patients with cardiomyopathies, I think the long-term needs are compounded by the fact that of that genetic component as well. So they've got the signs and symptoms that they have to deal with in the cardiac, physical side of things, but then you add this emotional effect of the genetic disease. And this is mainly modulated by variability in genetic conditions, so variable penetrance. You have patients who live a very long life where the cardiomyopathy might be a bystander in their overall health. You can get somebody very young with lots of signs and symptoms, and people in the middle with lots of signs and symptoms, but they can be manageable. So that can create a lot of these things sort of surrounding this wheel. And then, of course, the lack of diagnosis or inappropriate care. So, I mean, a lot of you have patients who are in the gray area. They don't tick quite all the boxes for ARVC, don't quite tick all the boxes for HCM, but then they're treated as someone with disease, and again, that can also cause a lot of anxiety. So, yeah, anxiety is a major emotional effect in genetic conditions, and in particular, the ICCs. Then, of course, worry about risk to children because these are dominant conditions. So first-degree relatives are at 50% risk. Guilt of having to potentially passing on a condition. Anger, because a lot of people actually try to do the right things in life, and yet they still end up with a heart condition. Uncertainty. So, people who are carriers sometimes think, what is my future? Am I going to develop this disease? Sadness and grief. Patients may have lost a loved one, or they may actually lost their own position in their families, in their jobs, in society as a result of the illness. And then, of course, depression, which surprisingly doesn't play a big role in ICCs. It's more anxiety. But there are still patients who will go into very deep depression as a result of the condition. And redemptive adjustment, which is actually a positive thing. So it's said that if people get affected with inherited conditions, sometimes it actually brings out the best in them. It's because it harnesses all the positivity and motivation to kind of just be the best for their families and be the best for themselves. Okay. And just going back to the inherited cardiac conditions clinic, this is one study done by the Australian team looking at the impact of having a multidisciplinary clinic on the psychological health. And they found that patients who are seen in a specialist clinic are better adjusted to the condition and worry less. So an integrated approach is much more suitable. But here, the confidence intervals are quite wide, and this is one center, so I think it's very difficult to draw conclusions from that. But it's a good sign that an integrated approach can also help as a supportive mechanism for patients. But also in this same study, they found out that only 24% of HCM patients are adjusted to the condition, and 10% of HCM patients and 40% of at-risk patients have low worry scores. So really that means there's still a lot of this psychological distress bubbling about despite being seen in this multidisciplinary clinic. Other findings in the literature, patients who attend a screening clinic, whether it's because of a history of sudden death, cardiomyopathies, or arrhythmias, there is a high level of anxiety when they attend. And depression and anxiety tends to be consistent within families. So the variation is between families, but not amongst family members. And that's important to consider, because if you've got one anxious patient, you might have to take a family approach, because it's likely that this does impact on their whole family as well. And increased heart-focused anxiety. Some people are, because they fear that engaging in physical activity or in social situations will cause signs and symptoms, then they will tend to withdraw. And then in this study by Muhlenkamp, young children were really worried of dying suddenly. So that's very, very sad, especially if these are very, very young people. I think they studied teenagers and young people. But there is a flip side to this, and the good news is some studies show that the quality of life in patients who are healthy carriers of inherited cardiac conditions equal that of the normal population. But this is modulated by if people develop symptoms or they have fear of cardiac arrest. So again, there's a window there for some support. And then adjustment and hope prevails after initial period of high anxiety and distress. And on a whole, screening, diagnostic and predictive genetic testing does not adversely affect psychosocial well-being, even if they get a positive or a negative result. So there is something there that's helping patients get from a high level of anxiety up to getting some sort of calmness and normalization. And it could be, they're just a little bit more motivated. These patients could be in that sort of category, or there are other factors within the clinic or within their support system that help them overcome this. And so going on to psychological support, there's a lot of where's, what's, how's, and when's. But, unbeknownst to you, probably you are providing this day in, day out in your clinics, because there are many forms of psychological support you can provide to your patient. So, of course, there's always that formal route where you're referring directly to psychological services or referring to bereavement counseling. And family therapy has been found to be very effective in families with genetic conditions. And even having additional sessions with a cardiac genetics nurse or a genetic counselor can be helpful, because they are trained in motivational interviewing, non-directiveness, that can help support the patients a bit more. Then, of course, the informal psychological support, where even just checking in and asking patients how they are. I think that's really important to them, that, that you ask them how things are going. Mindfulness and relaxation techniques, which can be just taken off the rack, really. These are very, very accessible. And then, of course, support groups, which I'll talk about in more detail later on. So there's many, many ways that we can provide psychological care, and one or more forms may be necessary and at different times as and when the patients need it. At Guy's and St. Thomas's, one of our MSc Health Psychology students, Alison Golder, we did a sort of a pilot of a program that's kind of ongoing within the trust. It's called IMPARTS, or Integrating Mental and Physical Health Care Research, Training and Services. So this is a package that includes early assessment of psychological issues alongside outcome measures, which triggers care pathways, and they provide the training and their self-help materials to help patients. And then because of the way the data is collected, it lends itself very well to research studies. And in our little pilot that was done, 24 patients with ICCs were contacted, and it looks like the program is feasible, but you still need that extra staff. So I think we have to figure out how a better way to streamline this to lessen the impact on staff. And they found that 50% of people were anxious prior to the consultation, but the majority felt negative feelings improved after the consultation. So, that means that the clinician is quite good at being able to allay fears and anxiety. Interestingly enough, 50% felt that they did not need to bring up psychological support needs with the consultant. This is unfortunately quite a consultant-focused sort of study. So we still probably need to see the impact or the role of the cardiac genetics nurse in this particular field. And 33% felt that their needs were discussed. So again, hopefully trying to scale this up and see how effective this project will be in our clinic. In terms of lifestyle advice, I'd really just like to focus on exercise, because there is still a misconception amongst clinicians and also patients that once they get diagnosed with cardiomyopathy, they can't exercise. And that's, although true for some people who are very unwell and certain conditions, the majority of patients with cardiomyopathies can exercise. And this is a study done by, again, the Australian group, and they looked at the amount of exercise that cardiomyopathy patients do and the barriers to exercise. And they found that patients did considerably less exercise than the average Australian. But the barriers to exercise were quite interesting, because the top two, fair enough, if you're very unwell, you're not going to exercise, you're not going to feel up to it. But the ones at the bottom, even I use these excuses. So I think, there is a lot of room for us in supporting our patients, encouraging to exercise because of all the benefits of it, both physically and psychologically. And I came across this website from the Peter Monk Cardiac Centre based in Toronto, and I encourage you to look at it yourselves, because in this tab where it says HCM fitness programs, you scroll down to it, they have a beginner and then up to like sort of higher intensity exercise. And it not only shows pictures of the exercises, but there's also modifications if somebody's got an ICD, and also videos of the exercise. So I think, my challenge to the exercise experts out there in the audience is also maybe develop something with a local flavor, and also maybe kind of in cardiac rehab plans have something specifically also for cardiomyopathy patients. Number 6, patient and family-centered care. It's very important. In the literature, children are the primary motivation for patients engaging in screening or genetic testing. So if that's their top of mind, is their children, it should be ours too. So I think when you're recommending children for screening, make sure it's done in a timely manner. And when you're saying to a patient, we're going to start screening at 10 years old, or you're saying, oh, we don't need to screen your children because you're clear, not affected, take time to explain those two things, because you don't want parents walking away thinking and having that doubt that their children aren't safe. And consider the developmental period. So, a teenager with cardiomyopathy might be needing some transition support into the adult services. And also if you've got a young couple, prenatal and pre-implantation genetic diagnosis is important to consider, particularly if there's a mutation found in the family already, because what you don't want is, a heavily pregnant couple with a baby at risk for cardiomyopathy, and, they actually, wanted these options and it wasn't offered to them early. Family communication. Always remember that the person, the proband or the affected person in front of you is the gateway to other family members, to keeping them getting them screened for cardiomyopathies. So make sure that this is also supported, that they relay any information to the family if they need screening. So think about your duty to the patient, but also your duty to their families. And a final bit here is advocacy, because a lot of patients, they have their acute episode, they go back to work, or they need a bit of social service support, and this is what they get. That you don't look sick at all. So I think as clinicians, we really have to advocate for our patients if they need that sort of letter of support of their health. Please give it in a timely manner, be as accurate as possible, and emphatic as possible. 7, updated genetics input. So it doesn't have to happen every year, but periodically patients with inherited cardiac conditions should have every now and again a look into their genetics notes, because new genetic testing techniques and panels always come up. Some years ago, FLNC and RBM20 weren't in our panel, so patients who we tested early we didn't detect a mutation, but with the updated panels, we were able to give the genetic diagnosis. Then also, there's a lot of reclassification of variants now that a lot of the variant databases are sort of really kind of gathering momentum. And I've had a family recently with a TNNT2 mutation. The variant ended up getting reclassified, and we had to recall all the family members who were negative for this genetic change because they needed screening again. Re-examination of the pedigree. It's a good chance to catch up with your patient, see what's going on, but also to see further opportunities for further cascade screening. They suddenly found out they had a long-lost brother somewhere. Opportunity for family studies, so if there's a variant found in the family, neither here nor there, but then suddenly other members through cardiac screening have been found to be affected, you can then do family studies to create a sort of a clearer picture of how that genetic change is affecting, impacting on disease. And because there are a lot of private mutations in cardiomyopathy families, that could be the clincher in turning around the classification of the variant. And updating the phenotype. So over time, patients may develop other signs and symptoms, or their other family members may develop other signs and symptoms. And as you see with the other talks, Perry and Jerry, everybody, that could be a syndromic condition. You just have to get to the bottom of that. And sometimes looking at periodically doing a genetic assessment on the patient is very rewarding. Number 8 is peer support. So at this moment, I think Cardiomyopathy UK is actually supporting us in our sort of education and training. But more importantly, their role is supporting the patient. And there's no better expert at giving advice day to day to patients than patients themselves who've had that lived experience. And there are many support groups. And I think our Alstrom syndrome support group is here today as well. So just a way of just making sure you signpost the patients to the appropriate ones, which is a good fit for them. And, there is a desire to help and be helped. And, patients are very motivated to take this up and also to contribute. Number 9, involvement in research and service improvement. So as we all know, there are many gaps in the knowledge. And also, there's always been a problem in research of recruiting minority populations. And, there's lots of benefits for the patients, the NHS, and the scientific community. So our patients actually are our best resource in guiding our research questions, making sure research is appropriate, and also then giving that, improving their care. So we are very active in recruiting for the 100K Genomes Project, and hopefully the outputs of this will, really greatly benefit our patients. And just to introduce our King's Health Partners Patient and Public Involvement for Inherited Cardiac Conditions, or PIC. So personally, in my own research, they've really guided me in making sure everything is, information leaflets are easy to read for patients, that my research is applicable and practical, and even the intervention model that I'm going to try and come up with, they're going to be helping in refining that. And more importantly, they've also put a great input into our patient pathway and to try and improve services. So please don't accuse me of child labor. I like to think that we're child-friendly, but this is our amazing patient and public involvement group. And I guess from the research grant point of view, no PPI, no grant. And number 10, I hope this isn't a surprise. It's the cardiac genetics nurse, which is really important to address and help with the long-term needs of your patients. So the cardiac genetics nurse is a liaison between the patient and the clinician, other clinicians, and other services, and really, it's the first point of contact for everything, really. So having a cardiac genetics nurse who's named and will kind of be giving that consistent care and constant presence is really quite a comfort to patients, and also good for the service as well, because they can make sure you're all on track, okay? I leave you with this graphic, which was part of the work done by my colleague Laura Monya Garcia when she was still at Imperial. But I think it really illustrates, what patients are feeling, what they need, and also how they want to contribute to improving their own care. So thank you very much.